Welcome to another EduMed video, and this is another in the series on ITU ward rounds. And in this one, we'll be talking about communication with next of kin. We'll try and cover what should be communicated on a daily basis with the next of kin, how you should communicate these things, and common mistakes that are made when talking to next of kin. The aim should always be for daily communication. You should be touching base with the family, updating them as to what's going on. And in terms of the update, you should tell them about the progress that the patient has made, or any deteriorations that the patient has had, any procedures that are planned, and always try and reiterate that whether a patient is getting better or worse on a day-to-day basis is less relevant than the overall trajectory of the patient. And that even if a patient seems to be getting better each day and then suddenly gets a pneumonia, for example, that is totally within the realms of normality, and that with intensive care it's more about a week-to-week changes rather than a day-to-day. I can't emphasize enough how important it is to speak to the family and make sure that they appoint one single point of contact. This is someone who ideally can come in most days so that we can update them, and then they can sensibly disseminate that information to everyone else. It is not uncommon for families to have multiple people coming in, and if you're trying to update multiple people on each single day, you will end up spending all of your day just trying to communicate with one family. It is not an efficient use of your time and often will lead to miscommunication between family members. So by appointing one person who will be the link person for the medical teams to talk to, ideally the person who is the direct next of kin, but it can be anyone, and as long as the family have agreed and the medical teams have agreed that it's an appropriate person, then just discuss things with them. And anyone who else asks for information, the bedside nurse may be able to give a small snippet, but always refer them to that nominated next of kin to give them the full update. Communication is always best in person, because then you can sort of detect body language, you can see if there are any questions, and you can gain a bit more rapport with the patient's next of kin. If you are calling, check with the ITU policy. Some ITU policies require that patients are only discussed face-to-face with next of kin. If you can do phone updates, then just check that the patients don't have passwords in place. There are certain next of kin who the family may not want updated, and also especially in criminal cases there may be passwords put in place so that only the family can be updated. This is especially important in high profile cases where you may find journalists trying to find out things about patients, and you don't want to divulge information unnecessarily to people who the family do not want to get that information from. There are multiple benefits to communication. The family can actually guide you quite well as to what the patient wishes. It's not uncommon for us to plan multiple different interventions only for family to actually say they wouldn't have wanted it, or if that would mean that the patient's chance of recovery is less, or they would end up in a nursing home, they wouldn't want those things. So having early involvement with the family is always critical and can sometimes prevent you from giving treatments that are not in the patient's best interest. It can also help family come to terms with what's happened to the patient and help the patient actually understand what happened to them when they're recovered enough, or if they deteriorate, it gives them a great sense that you've done everything you can for them and that you've brought them along this journey, as opposed to suddenly turning around and saying that their loved one has passed away. And there is a lot of evidence suggesting that good communication with families leads to much less complaints, which, although isn't our driving factor in medicine, is always a benefit. Common mistakes that are made are talking to multiple different members of family. It goes back to that point about having a nominated person that all the information goes through. The reason for this is different people have different agendas. They have different levels of comprehension, and you may not have been able to explain everything in as much detail as you would have been able to if it was the same person coming day in, day out. The other common mistake is giving people false hope. People who come to intensive care are critically unwell, and about half of those people will end up dying in the next year or so. So, saying that someone is getting better, but they're still on 2 mics of NORAD, they're still on 100% oxygen, but you've managed to bring down their oxygen from 100% to 95%, they're still within the realms of being critically unwell. And you will often see patients getting better over periods of time and then suddenly taking a step down. Or some patients spontaneously have myocardial infarctions. So although it's good to tell patients' families that patients are heading in the right direction, it is always worth reiterating that till they've come out of the intensive care, or at the very least been extubated, anything can happen. The other thing that can happen, which does happen quite often, is that you can set unrealistic expectations. If you update a patient's family every single day, they will start to think that it's a natural thing, a matter of course, and then get angry if they're not getting updated every day. So do set some expectations with regards to updates and say, look, if nothing's happened throughout that day, I'm not going to come and talk to you as the doctor, but the nurse at the bedside can tell you the highlights of what's happened. And then limit what you're saying to the really key things that change maybe every few days, if that's possible. And the other thing that a lot of family members understandably want are timelines. They'll say, how long do you think my patient will be in intensive care? And the honest answer is, you have no idea. Because even if it is a barn door pneumonia where it looks like the patient is getting better, they could be getting better and better and then suddenly have an MI. So always say that you're not sure. You'll have to take it day by day, week by week. But in general, for most patients, we're talking about weeks in intensive care. And so set that expectation that this is something that's going to take a long period of time. And always set the expectation of things going wrong. And so if it doesn't, fantastic. But if it does, it doesn't come as a surprise to the family members. So in summary, communication is vital. It's one of the most important things when you're dealing with a family. Try to build in a routine of speaking to family members, usually sort of after the ward round, after you've done your major bits of work. So it's usually in the afternoon, evening time. Don't forget to communicate with the base team as well. It's one thing to communicate a lot with the family, but do make sure that you've got the base team that the patient came in under is involved in those conversations, because what you don't want to do is to be saying one thing and then when they speak to, say, their medical team or their surgical team, they say something totally different. The base team should also be in contact with the next of kin. It's important for them to build up a rapport to show that intensive care is part of the greater team. It's not that intensive care is a separate treatment to the treatment that the base team are giving. And often that builds in a bit of rapport with the base team as well, so it's easier to make shared decision making between the intensive care and the base team that the patient is under.